You know, when we think of detectives, we usually picture crime scene tape, maybe a magnifying glass, a smoky room, and some noir film. But there's a kind of detective work that happens every day in these bright, sterile clinic rooms where the stakes are, well, they're arguably much higher.
And the clues are much harder to interpret. Because in this version of the story, the suspect is a lump in the neck. And the crime could be anything from a simple cold to a life-threatening cancer hiding somewhere else entirely.
That's exactly the premise of our deep dive today. We're looking at this fascinating piece of clinical source material. It's a guide for the FRCS exams.
The Fellowship at the Royal Colleges of Surgeons.
Right, so this is not, medical diagnosis for dummies. This is the masterclass. This is how the experts are trained to think.
It really is. It's like a window into the surgeon's brain. The neck is this incredibly complex piece of real estate. You've got the airway, the food pipe, major blood vessels going to the brain, nerves, glands, lymphatics.
All packed into a tiny space.
It's all packed into a very tight cylinder. So when a swelling appears there, it's chaos.
It's crowded.
It's very crowded. And the surgeon's job, the detective's job, is to walk into that room, touch that neck, and within minutes filter through hundreds of possibilities to find the one truth. And the source material frames this not just as biology, but as a rigorous logical pattern.
And that's our mission today. We want to extract that pattern to understand the logic. As a guide makes it so clear. You can't just poke a lump and guess. You need a framework.
You absolutely do. And the framework it proposes is a triad. 3 steps: anatomic localization, pathological nature, and etiology.
Which, in plain English, is where is it, what is it, and what caused it?
Spot on.
Yeah.
And you have to do it in that order. If you skip where is it and jump straight to what caused it, you will miss the diagnosis. For example, the neck is divided into these geometric triangles. A lump in the front triangle has a completely different list of suspects than a lump in the back.
So geography is destiny here.
To an extent, yes.
Okay, so let's start with the most likely scenario. The guide says that, statistically, if you find a lump in the neck, it's overwhelmingly likely to be one thing.
A lymph node. Cervical lymphadenopathy, that's your usual suspect.
But, and this is a big but, in the text, just identifying it as a lymph node doesn't solve the mystery, does it? The text says the list of reasons a node might swell is vast.
It's huge. Think of a lymph node as like a police station. If the station is busy and crowded, it tells you something is happening, but it doesn't tell you what. Is there a riot? Is the station itself under attack? Or is it just a false alarm?
So how do you tell the difference? The guide seems to rely so heavily on profiling the patient.
It does. Context is everything. Let's take a really common scenario. A 5-year-old kid comes in. His mom is worried she found a lump. You feel it, and it's rubbery, it's mobile, so it slips around easily, and it's tender. The kid winces when you touch it.
Usually pain is a bad sign, right? We tend to think pain equals something really wrong.
In the neck, pain can actually be reassuring. That profile, young, rubbery, tender, usually points to a reactive or inflammatory node. The police station is busy because it's fighting a fire somewhere else.
So the lump isn't the problem, it's the reaction to the problem.
Precisely. And the guide says, stop looking at the neck, look at the tonsils, look at the scalp. Did the kid have a sore throat last week? An ear infection? If you find these huge red tonsils, you've solved the case. The node is just doing its job.
Okay, so rubbery and tender in a kid is usually fine, but let's flip that profile. Now you have a 65-year-old patient, a heavy smoker maybe, and the lump feels totally different.
This is where the mood in the room just changes. If you find a node that is hard, rock hard, non-tender, doesn't hurt at all. And crucially, it's fixed.
Fixed as in glued down.
Yes. You can't wiggle it. It feels anchored to the deeper tissues.
Yeah.
That's a massive red flag. That is metastatic carcinoma until proven otherwise.
And the detective work here gets really specific about location. The text mentions Virchow's node.
Ah, yes. The Treusler sign, or Virchow's node. A fascinating bit of anatomy. It's located specifically on the left side, right above the collarbone, the supraclavicular fossa.
And why the left side? What's so special about that?
It's all about the plumbing. The main lymphatic duct from your abdomen, the thoracic duct empties into the bloodstream on the left side of the neck. So if you have a cancer in the stomach, or the pancreas, or the testes,
It travels all the way up to the neck.
it sends a signal right up the highway. So you could be palpating a neck, but you're actually diagnosing a stomach tumor.
That is terrifying, but also incredible. It connects the whole body.
It does, and that brings up a critical action from the guide. If you find this hard-fixed lump, your first instinct might be to just cut it out, biopsy it. But the guide says no.
Why not? Don't you need to know what it is?
You do, but if you just excise the lump, you're shooting the messenger. You have to find the source. The critical action is a full head and neck exam. Look at the mouth, the larynx, the ears, the scalp. You find where the enemy launched the attack from before you worry about the node.
So we have the good nodes, the reactive ones, and the bad nodes, the hard cancers. But then the text goes into this murky middle ground, the great mimickers.
Tuberculosis and lymphoma, the classic diagnostic showdown.
Let's start with TB. I feel like most people think of TB as, Victorian lung disease, coughing into a handkerchief. I didn't realize it shows up in the neck so often.
Oh, it's a very common presentation. Tuberculous lymphadenitis usually affects immigrants from regions where TB is endemic, or sometimes the elderly. And the physical description, well, it's quite visceral.
Matted. That was the word that stuck out.
Yes. Unlike the reactive nodes, which feel like separate little grapes, TB nodes stick together. They fuse into this clump. It feels like a matted mess.
And then they break down.
They do. They form what's called a collar stud abscess. And visually, it's distinct. A normal infection is hot and angry. A TB abscess is called a cold abscess. The skin turns this eerie reddish purple, but it doesn't feel hot.
That's such a specific detail. A cold purple lump. Okay, contrast that with lymphoma, because the demographic shifts completely here, doesn't it?
Drastically. With lymphoma Hodgkin's or non-Hodgkin's, we're often talking about young adults, late teens, early 20s, and often men.
And the texture.
Rubbery and discrete, that's the key phrase. Discrete means separate. You can feel individual, firm, rubbery bumps. They aren't matted together like the TB nodes.
But the real giveaway for lymphoma seems to be the story the patient tells you, the B symptoms.
Right. Unexplained weight loss, fevers, night sweats. And we don't mean just feeling a bit warm. We mean drenching the bed sheets.
But there was one detail in the source material that I found absolutely wild. It's listed as a curiosity, but it's specific to Hodgkin's lymphoma, alcohol-induced pain.
It is one of the strangest phenomena in medicine. It's rare, but it happens. A patient, usually a young person, drinks a beer or a glass of wine, and within minutes, the lymph nodes in their neck start to ache.
Do we even know why?
The theories vary. Some think the alcohol causes the blood vessels in the node to dilate rapidly, stretching the capsule. But honestly, we're not sure. But imagine you're the detective. A 20-year-old walks in and says, "Doc, my neck hurts every time I go to the pub."
You'd think he was joking or making excuses.
You might, but if you know the pattern, that sentence rings a massive alarm bell. It's a huge clue for Hodgkin's.
It really highlights how much of this is just listening, not just looking.
Absolutely. So that's the lymph nodes, the biggest category. But then the guide pivots. It asks, okay, what if the lump isn't a node at all?
The weird ones, the structural glitches.
Right. These are often congenital issues, things you were born with that just decide to show up later in life.
Let's talk about the branchial cyst. The embryology here is just fascinating.
It is. When you were a tiny embryo, you had these things called branchial clefts. They're structures that eventually fuse to form your neck and throat. Think of them almost like gill slits that close up.
But sometimes they don't close perfectly.
Exactly. A little pocket gets left behind. And it can sit there, totally dormant, for 20 years. Then suddenly, in early adulthood, it fills with fluid and pops up.
And the location is the key clue here, right?
Location is everything. It almost always appears poking out from under the sternomastoid muscle. That's the big strap muscle that pops out when you turn your head.
So if you see a smooth, egg-shaped lump emerging from under that muscle in a 20-year-old.
You're thinking branchial cyst. And because it's a cyst, it feels fluctuant, like a water balloon, not solid.
Speaking of solid, let's move to the potato tumor.
Chemodectoma, or carotid body tumor.
Why potato?
It's described as having a potato-like consistency, firm, solid. But the real trick to diagnosing this one is physical mechanics. This tumor grows right at the fork of the carotid artery, the main pipeline to your brain.
So it's physically attached to the artery.
Right, and since the artery runs vertically up and down the neck, you can move the tumor side to side.
But not up and down.
Exactly, it's tethered on a track.
Now, the guide had a huge warning box next to this one, an OSCE safety alert. It basically said, do not touch this, or at least be careful.
It's a serious warning. The tumor sits right on the carotid sinus. That is the body's pressure sensor. It tells the brain what your blood pressure is doing.
So if you poke it.
If you massage it vigorously, trying to figure out what it is, you trick the body. The sensor thinks blood pressure is just skyrocketed, so the brain slams on the brakes.
And the patient passes out.
Vasovagal syncope. You can drop a patient right there in the exam room. It's a profound reminder that diagnosis is not a contact sport. You have to be gentle.
First, do no harm, including gravity-related harm from fainting. Okay, noted. Don't squeeze the potato.
Good rule of thumb.
There were a couple of other oddities. The glow-in-the-dark lump.
Ah, the cystic hygroma, usually seen in infants. It's a soft, squishy swelling at the base of the neck. Looks scary, but the diagnostic trick is magic. You take a flashlight and press it against the lump.
And it lights up.
Brilliant transillumination. It's filled with clear lymphatic fluid, so the light shines right through it like a lantern. If it were a solid tumor, it'd be dark. It's a beautiful, simple test.
From the beautiful to the, well, the socially awkward, the pharyngeal pouch.
Zenker's diverticulum. This is a tough one for patients, usually older men. It's essentially a hernia in the throat lining. A pouch forms where food can get stuck.
The symptoms were brutal. Halitosis, really bad breath, and regurgitation.
But specifically, regurgitating undigested food onto the pillow at night. The patient eats dinner, goes to sleep, lies flat, and gravity just empties the pouch. They wake up choking.
And can you feel it? Is there a lump?
Sometimes. If it's full, you might feel a mass behind the muscle, and the text uses a phrase that just makes my skin crawl a bit.
Yeah.
A gurgling mass.
Oh, that is vivid.
If you press on it, it gurgles. That's practically diagnostic right there.
Okay, one last weird one. The sternomastoid tumor. The name sounds scary, but this is in newborns, right?
Yes, and tumor here is used in the old Latin sense of just swelling, not cancer. It's actually fibrosis, a scar.
What causes a baby to have a scar in their neck muscle?
Usually birth trauma. If the birth was difficult, the muscle can get a little tear. It heals with this hard lump of scar tissue.
And that tightens the muscle.
Right. It pulls the head to one side. We call it torticollis. The baby looks like they're permanently tilting their head. Parents are terrified, but the verdict is great. It's benign. It usually goes away with just physiotherapy.
That's a relief. Okay, let's move on. We are heading into the mouth well, the plumbing that feeds the mouth. Salivary gland pathology.
Salivary glands are tricky. The most common issue here is simple mechanics. Stones. Silothiasis.
Like kidney stones, but in your spit glands?
Exactly. And the clue isn't the lump itself, it's the timing. The mealtime clue.
The patient notices it when they eat.
The patient will say, "Doctor, my face swells up and hurts every time I sit down to dinner." Think about the physiology. You smell food, your body starts producing saliva.
But the exit is blocked by a stone.
Right. It's like kinking a hose with the tap on full blast. The pressure builds up, causing pain and swelling. Then, you finish eating, saliva production slows, and the swelling goes down.
So if the pain is linked to the menu, think stones. But what about tumors? The source gives us some really handy statistics here. The rules of 80.
This is a classic surgical rule of thumb for the parotid gland, the big salivary gland right in front of your ear. Rule 1. 80% of all salivary tumors are in the parotid.
Okay.
Rule 2. 80% of those parotid tumors are benign. Usually something called a pleomorphic adenoma.
So big gland usually means benign. That's comforting.
It is, but then there's the inverse rule.
Which is?
The smaller the gland, the higher the chance of malignancy.
Wait, really?
Yes. If you find a lump in the tiny minor salivary glands, like the ones inside your lip or on the roof of your mouth, you should be very worried. It's much more likely to be cancer than the big lump on the side of the face.
That feels so counterintuitive. You'd think the big scary lump is the bad one.
Not in salivary land. And speaking of bad ones, there's one massive red flag for parotid tumors. Even in the safe gland, what should we watch out for?
The facial nerve?
The facial nerve. It runs right through the middle of the parotid. Now, benign tumor, it pushes the nerve aside politely. But a malignant cancer,
Doesn't ask permission.
it invades. It eats into the nerve. So if a patient has a lump in front of their ear and they can't close their eye on that side, or their smile is crooked,
That's a major danger sign.
it is the ultimate danger sign. The text emphasizes that checking facial movement, show me your teeth, close your eyes tight, is a critical action. If you don't do that, you can miss the cancer.
It's just amazing how much information you can get before you even scan or biopsy anything. But we've covered a massive amount of ground here. Matted nodes, lighting up cysts, gurgling pouches. How does a doctor keep this all straight without panicking?
That brings us to the final piece, the master checklist. The source provides an acronym as a mental filing cabinet, the ABO pattern.
Let's unpack it. It's actually A through E.
Right. It organizes everything by cause. Stops you from guessing. So A is for acquired. That's your infections, your TB, your reactive nodes, the things you catch.
Okay.
B is for benign or maldevelopmental.
Okay.
That covers our branchial cysts and the carotid body potato tumor. Things that are structural but not cancer.
C must be congenital.
Things present at birth. The cystic hygroma in the baby. D is for degenerative. That's the pharyngeal pouch. It's wear and tear on the throat muscles causing that blowout.
And finally, E.
E is for everything else. And in the world of neck lumps, everything else is the category you never want to miss. Malignancy. Cancer.
A, B, C, D, E. It really does turn a chaotic list into a structured ladder.
And that's the whole goal.
Yeah.
It's not about memorizing a textbook. It's about walking into a room with a scared patient and having a logical path to follow. Anatomy, nature, etiology.
It transforms a mysterious lump into a solvable puzzle.
It does. And I want to leave us with one final thought, going back to that carotid body tumor warning.
The don't press too hard rule.
Exactly. I think it's a profound metaphor for diagnosis and maybe for how we solve problems in general. We often want answers immediately. We want to poke and prod at a problem, dig into it vigorously until we figure it out.
But if you press too hard, you might cause a faint.
You might cause real harm. Sometimes the best diagnostic tool isn't brute force. It's a gentle hand, a sharp mind, and a respect for the patterns. Whether it's a delicate tumor on a vital artery or a complex issue in our own lives, sometimes you have to step back and observe the whole picture before you dive in.
Diagnosis as a balance of curiosity and caution. I love that. So next time you face a complex problem, maybe try the ABO method, categorize, analyze, and don't press so hard you knock someone out. Thanks for joining us on this deep dive.
My pleasure.
See you on the next one.